our case discussant Asha. So, welcome to a new episode of Medad CR. Today, I think, is quite different since both our advisor and presenter are from Cleveland Clinic. So, I guess it's a different experience for us, and it's a foreign environment for us as well. So, without further ado, Dr. Fahad, you might take the lead.
All right, I'll just probably switch on the camera just for you guys to know who you're talking to. So first of all, I'd like to, commend, the group who started this. This is really, great. I hope none of us are foreign. We're all here. And, I think the objective is to learn. I want to say just one key message as we go through this case. The fact that we are a Saturday morning at around, 9 or 10 o'clock and wanting to learn, that tells us a lot about the group and the willing to learn. So, we're going to go through this case and we'll make it kind of a group discussion, allowing people to ask questions in between. And it's an honor to be on board.
Dr. Sarah, you might want to start.
Yeah, hi, good morning, everyone. My name is Sarah Al-Qasimi, and I'm an R1 internal medicine resident at Cleveland Clinic, Abu Dhabi. This is my second episode with you guys, so I'm happy to be on board again.
Our case discussant Asha, are you here with us?
Hello everyone, I'm Asha Ali Tanhani from University, 6th-year student. Thank you.
All right, so Dr. Sarah, I think you can make a start right now.
All right, let's start the case. You have a 38-year-old female who's coming in for lower limb edema for 1 day. Now, Aisha, how would you like to start this? How would you like to start thinking about a case who comes in like this to you?
Okay, so first I'll begin with, is there anything else other than edema?
No, it's mainly she's coming in for the edema, nothing much else.
Okay, is this the first time she has this?
Yes, it is the first time that she has this.
Is it both legs?
No, it's only on the left side.
Okay.
And,
Is there
and
any-
if I can just interject for 1 second,
Sure.
actually, I have to commend you, Aisha, on this comment, because the first thing I would think about any organ system or limb in the body is to ask about symmetry. And symmetry actually opens, the whole life of possibilities, because it tells you whether this is a problem related to a generalized systemic illness, or it's a problem related to a certain anatomical structure that feeds into that leg or arm and things like that. So I think that's a very important point. And I would actually ask this the first thing, is it one legs or two legs? And then you can take it from there. Excellent.
Okay, is there any pain?
Yes, there is a lot of pain actually.
Okay, and have you taken any medication for this pain?
She's tried taking paracetamol and mefenamic acid, but they did not work at all, and she still feels pain even after taking those medications.
Okay. Does it feel cold?
To her, it doesn't. She doesn't really feel the cold because when she touches it, it's painful. So she doesn't really touch it.
Does the pain radiate, for example, from the back to lower limb or
No, it's mainly the leg that's painful. The whole leg, the whole left leg.
okay. Does she has any fever?
No, she does not have fever.
Okay.
If you don't have any additional questions, I can present to you the whole HPI. This is a good start, by the way. So if you don't have anything else, I'll just start on presenting the HPI. Is that okay with you, Aisha?
Yes, okay.
Okay. So this is a 38-year-old female, known case of endometriosis. She's presenting to the ER with the left lower limb edema. She reports that for the past 5 days now, she's began to feel pain at the level of her coccyx, which she describes as a constant sharp pain. This pain then migrated down to her groin and leg a few days later and was getting sharper and increasing in intensity day by day. However, one day ago, she noticed increased swelling of her left leg with severe pain. She was no longer able to walk on it and had to drag her leg whenever she tries to walk. And as I mentioned, she tried paracetamol, mefenamic acid, but they did not relieve her pain. Her leg was very painful to touch, and her skin blanches whenever she touches it. She was recently diagnosed with endometriosis 2 months ago and was started on an OCP, which she reports good compliance with. Okay, now that you have this HPI and you've asked a few of your questions, do you have any additional questions that you'd like to ask?
Does she has any medical problems?
Other than endometriosis, no.
Okay. Does she take any medications?
Other than the OCP, no, she does not.
Any trauma?
No recent trauma, no.
So can I interject?
Yeah, of course not.
All right, guys. So a few things. One of my dreams is actually to go back to medical school, and I'm serious about this. And maybe my wife thinks I'm a bit crazy, but there's so much joy in medicine and learning medicine. The idea about this case is very, very interesting. And, as you guys are, mashallah, senior medical students, you're about to go, to practice. The type of questioning, Aisha, you're asking is very valid and it's very helpful and it's very kind of online clinical, where you're thinking about diagnosis and you're trying to figure out whether this patient has a diagnosis or not. Meaning, is this acute limb ischemia? Does they have cold feet, right? Has the patient fell? Does she have trauma? Now, I'd like to take a few steps back, and I'm just going to give that introduction thing. The HPI still remains the most important da'a'im. It's the main thing where the history hinges. So the first question I was asked is, where is the pain? And I'm going to spend maybe 2 minutes just kind of back and forth with Sarah. Sarah's doing a very good job with the history, just to kind of ascertain. So Sarah, point to your finger where the pain is.
Sure.
I know we can see you, but where is it?
It's the left leg,
Where exactly in the left leg?
the whole left leg.
Is it in the front? Is it in the back? Is it around where the tibia is? Is it where the calf?
Front, back, everywhere.
So it's the whole leg. And then that's a
Yes.
very important concept, right? Because it's not a single compartment. It's not the tibia. It's not the calf, right? This is where the site is. What's the
Correct.
description of the pain? How do you describe the pain?
Severe. Very
Okay.
severe.
Okay. So severe pain. And is the pain onset gradual or sudden?
It was gradual, and then she felt it was sudden.
Okay. So this is very important because there are certain pains that occur suddenly, and there are certain pains that become intermittently. So I'll open it to the group. What kind of leg pain occurs suddenly, and what kind of the leg pains occur intermittently? And you guys, you're in a safe place. It's a Saturday and everything is great. I see names. خذوا راحتكم يعني everybody is here. أشوف they're Arabic, right? Yeah. خذوا راحتكم. Just answer away. Quick example. For example, intermittent claudication is classically a pain that happens with walking and exercise, right? Acute limb ischemia happens suddenly. Acute DVT happens suddenly or gradually to suddenly because it's a venous occlusion. Okay, so we're going to have these in mind as we tackle through the history, because there are more easier histories like chest pain, like abdominal pain, and there are more difficult ones like leg swelling, for example. All right, Sarah, and take it away. You're an Aisha.
Okay, Aisha, after that introduction about the HPI and Dr. Fahad's comments about it, what now are you thinking differential wise? What is on your mind?
So DVT, acute limb ischemia.
Okay. And what goes with and what goes against those diagnoses?
So it is sudden. I think of acute limb ischemia and DVT.
Okay.
And since it's the whole leg, I don't know. If I could exclude the claudication.
Okay, that's a fair differential so far. Um, any other questions that you'd like to ask before I move on to the rest of the history?
Does she take any contraceptives?
I'm sorry, what?
Contraceptive use.
Yes, she does. She
Excellent question.
started on it
Excellent
2 months
question.
ago.
What does she take?
Droperisone ethinyl estradiol. It's an OCP, yes.
Okay.
It's been 2 months now since she started taking it, and she's taking it on time and compliant with it and everything.
Okay, so this raises our concern about the DVT.
Very true. Yes. What are other things that you have to think of with DVT? What are other risk factors that you can ask? That
Yeah,
maybe
and
she doesn't have, but
travel,
it's
long sitting.
yes, correct, correct. Anything else?
Only this.
All right. So I'll just go through the review of systems very quick. I realized I didn't do that. So she denies recent trauma, fevers, chills, no cough, no shortness of breath, no dyspnea, no chest pain, no palpitations. She doesn't report abdominal pain, tingling, numbness of her lower limbs. Okay.
Okay.
All right. For her past medical history, only endometriosis, a medication she's only taking an OCP. She's allergic to augmentin. No past surgeries or recent surgeries. Her family history is unremarkable. Her social history, she's a non-smoker, doesn't take alcohol, and she works an office job. Anything here changes your differentials, Asha? Or would you like to add anything more to your differentials?
No.
All right. Okay. Would you like to move on to the physical exam?
Yes. So I'd like to ask about the vitals
Okay, perfect.
and then do focused leg examination, both legs.
Okay, and what are you trying to look for on the leg? You have this patient in front of you. Explain how you're going to examine her leg.
Okay, so I'm gonna examine your legs. I need to expose both legs.
Perfect. Okay.
Okay, I'm gonna inspect for any changes, any redness, any rashes, any deformities, any muscle atrophy, or yes, and I'm gonna look for a pitting edema. Uh,
Okay. Can you tell me what you're thinking of with each of those things that you're looking for? For example, the redness. If there is redness, why are you thinking of redness, or why are you looking for redness?
maybe inflammation.
Yep, exactly. And the other things as well. Like, tell us what you're thinking as well.
Okay, and I'm gonna look for 7 piece for acute limb ischemia, paleness, pulselessness, uh, pulselessness, sorry, and uh, I forget about 7
That's
piece.
okay. It's okay. No worries. Anything else on the exam? We're gonna go through it together.
Yeah, I'm gonna feel the temperature also. It's cold or hot. Mm. I'm gonna feel the pulses, and I'm gonna do a neuro examination also, the ortho,
Okay.
for the movement of the legs, and I could do straight leg test also for excluding sciatica, for example.
Okay. That sounds good.
Yeah, that's what I'm thinking.
Now we've discussed earlier that edema can be part of a systemic illness, correct? So on an exam, what other signs that you look for that could be systemic and causing an edema?
Okay, it's less likely because it's only one leg, so think of heart failure. I'm gonna
Exactly. Perfect. Yes.
chest examination.
Yes. What else other than chest examination where you're trying to look for signs of heart failure?
So added sound is a three, for example.
Okay.
Uh,
Excellent.
for respiratory examination, any crepitations, or for pulmonary edema.
Cackles. Yep.
Mm.
What about on the neck?
Yeah, raise JVP.
Yes. Can you think of any other systemic illness that can cause edema?
Yeah, a hypoalbuminemia, for example.
Okay, caused by what organ is usually the cause of that?
Kidney failure.
All right, very good actually. If I can just comment on the physical exam, I think يعني, the physical exam is very important. Now, sometimes we're distracted by the organ in question, meaning يعني, a leg. But if you entered into the emergency room or the clinic and you saw the patient, general inspection, you guys, is very important, okay? So I'm going to show you what the patient looks like, and I want you to tell me what do you think the diagnosis is, okay? I'm not that good in acting, but I'll see if you can guys see me. All right, so that's me, huh? So you enter the room, similar high, and then you see him doing this. So the patient is increasing his respiratory with this leg swelling. So what comes through your mind?
Pulmonary embolism.
عافية عليك. So you see how by just inspecting the patient, you guys, we've saved this patient life. Because if this guy has a DVT and I'm sending him next door to do an ultrasound or in the other office, and I've seen this before, um, seeing the patient, inspecting the patient is very important. فما عليك, you've made the right link, which is not an easy link to make, all right? Which means that inspection is extremely important. So examining the respiratory rate becomes very important, feeling the patient's hands, feeling the patient's pulse, right? Because the pulse might be tachycardic, the volume of the pulse might be high, or the volume of the pulse might be low, and doing further pericardial examination. Now, mashallah, you mentioned S3 gallop for heart failure, which I like. What is the other possibility in pulmonary examination that will support your PE thought?
Presence of tachycardia.
Sinus
Uh,
tachycardia, very good.
and
So, so when you have a pulmonary embolism, the right ventricle that feeds through the pulmonary artery becomes very strained. So you develop severe pulmonary hypertension and RV failure. And when you auscultate, the second heart, the P2, is usually loud with a pulmonic murmur. So this is called a pulmonic flow murmur that can happen in acute pulmonary embolism. So this is one possibility. Now, what's the other possibility of this breathing rate? In a unilateral leg swelling. So the patient tells you that over the last week I was playing football cousins في الفريج ودست مسمار حلي. This is kind of classical Bahraini history في الفريج. Presenting with this fast respiratory rate and severe leg pain, as Dr. Sarah mentioned.
Is it allergy? I don't know.
Okay, all right. So it could be an allergic reaction, but what else? If it's a dirty nail, and it's open to anybody.
Osteomyelitis?
Infection,
Yeah.
infection, right? So before it becomes osteomyelitis, it's an infection. An infection can cause systematic involvement, and patients might present with sepsis, manifested by a rapid respiratory rate as well, because they develop lactic acidosis. So that's another, I've seen this before. This is another possibility when you see somebody with a unilateral severe leg pain. We are trying to cover the 4 or 5 not misses, and that's the whole idea about يعني medicine. Okay, leave it up to Sarah.
Okay. So let's go over her examination. Vitals. Her temperature was 37. Her heart rate was 94 and regular. Her BP is 128 over 94. Respiratory rate of 17. And she was satting 99% on room air. So Aisha, what do you think of the vitals?
Yeah, stable.
Okay. On general inspection, she was in no acute distress. She was quite comfortable in the bed, actually. But this is likely because she had taken several doses of painkillers in the ER. She was given a lot of painkillers, so that was probably why. Cardiac exam was done. Pulse-wise, she had normal rate and rhythm. She had a normal S1, S2. She didn't have any murmurs or added sounds. Respiratory-wise, it was clear bilaterally. Air was also equal bilaterally. Abdominal exam, it was soft and non-tender. Neuro-wise, she was awake, alert, oriented. There were no grossly focal neurological deficits. And now we come to her musculoskeletal exam. Her left lower limb had clear pitting edema that reached to her groin. It was slightly cold and paler compared to her right leg. Her distal pulses were intact, but there was decreased range of movement due to pain whenever she moved it. There was blanching without cyanosis noted as well. So Aisha, what do you make of this exam?
So since she is stable and she already took painkillers, so
What does the exam rule out or rule in for you from the differentials that you put earlier from the history?
So I'm gonna rule out acute limb ischemia and pulmonary embolism.
Okay, and why? And tell us why you're doing that.
Yes, so for pulmonary embolism, she is stable and no respiratory examination findings.
Okay.
And I could rule in DVT because she's having the edema and wait. I'm not really sure.
It's okay. So at this point, what would be your top differential at the moment?
Mm. DVT.
DVT. Okay. Anything else that you feel like it could also be could be the cause of this patient's edema, and you want to work up and you want to um, rule out, or do you just want to investigate for DVT?
I'm not sure about lymph ischemia because she's feeling it is called lymph.
Yeah, it's still a fair differential, I think.
A quick comment. To be quite honest, unilateral leg swelling or leg edema or leg pain is a very common internal medicine, hospital medicine case. And you'll see that very commonly. And the two major differentials that bothers everybody is this a DVT or is this cellulitis, commonly. Acute limb ischemia does present more suddenly. The big fives, where the five Ps, I'm sorry, where the legs are pale, they're pulseless, perishingly cold, the pulses are impaired. So this self presents itself. Now, have you guys heard about the finger test? And I want everybody now to answer. Yeah, I see a lot of silence. So if you Google it, there's no finger test, okay? But what that means is as you examine the leg, and you have two diagnoses at hand. One is DVT and cellulitis. And you have two patients on two beds with your fingers approaching the leg at a constant velocity. Which patient is going to say, ouch, first? So you have a leg here, you're examining the legs and you're feeling the legs and you're touching the patient. As you touch the patient's leg, which patient is going to say, will feel pain first?
I don't know. Maybe the DVT one.
Okay, I like that. I like the answers. Answers is good. Anybody else, guys? I see a lot of names. Noura, Fatima, Muhammad, Irfan. There's
There's an
two
answer in the
Sarahs.
chat also, doctor.
Huh?
Someone said cellulitis in the chat. That's someone answering in the chat.
In the chat. Where's the chat? ما أشوف. Okay, finger test. This finger test is Trey, is it's my way of understanding the pathomechanics or the pathophysiology of pain. So if there is a DVT, where is the problem? The problem is in the deep veins. Where are the deep veins? One of the things that we really love is anatomy. Where is the deep veins? All right, guys. The deep veins is actually very deep within the gastrocnemius muscle, covered by the fish, which is the soleus muscle. One of the things I try to do enjoyably is to make sense of what you've done in anatomy and physiology and biochemistry throughout all those years. So you bring them back to clinical medicine and you fill them in accordingly to understand. So because deep vein thrombosis occurs very deep, pain and tenderness usually is elicited by deep palpation. The so-called modified Homan's test, and Sarah might talk about it, where you palpate with both fingers. Now, this is very important because cellulitis can also be elicited by tenderness to touch, but the pathophysiology of cellulitis is something called panniculitis. And that, write it down, because that is in the books. So panniculitis is inflammation of the superficial fat of the skin, and it is very superficial. So when you start touching the leg, the patient winches with pain, versus a DVT where the tenderness is much more deeper. So this is kind of something to identify. So the big three: acute limb ischemia, DVT, and cellulitis. And it's up to
So would you like to add cellulitis to your differential at this point?
I'm not sure, but I know.
It's okay. After that talk from Dr. Fahad, now what is your final differential list? starting from the one that you think is most likely in this patient, and then followed by the others.
Okay, DVT,
Okay. Number one differential.
lymph ischemia, and cellulitis. Okay.
Okay. Sounds good. All right. Now, with those three differentials in mind, how would you like to work up this patient? What are labs or imaging that you'd like to order? And you can start in order with DVT, what do you want? And with acute limb ischemia, how do you work it up? And then cellulitis, how do you work it up?
Just Sarah, before we go there, I think these three are the big three, and hopefully in future tutorials we're going to talk about target method, where like people who are doing archery, there is the red target, blue target, and yellow target. And the red target, as Sarah and Aisha mentioned, these are the big three. Other possible differential diagnoses of unilateral leg swelling can include osteoarthritis, Baker's cyst, and anything else, guys, you can think about? Now, rarities, but lymphatic interruption, right? When people have either leg surgery in the past, such as bypass surgery, saphenous vein salvage, as you salvage the saphenous vein, you strip away the lymphatics, so you cause a lymphatic inability of the lymphatics to drain the legs. That's another differential diagnosis. And even shway rarer, radiation induced. Okay, just to keep them lower down in the differential, but the big three is inshallah what we're going to talk about. Great job, guys.
Okay, so for DVT, I could do bedside ultrasound and check for femoral vein and popliteal vein.
Okay, that's a fair way to start with imaging. Any labs that you'd like to order to support the diagnosis of DVT?
I'm not sure about labs. I don't know if we could do a CBC and look for these platelets count. Maybe it would help us. I don't know. What do you think?
Or
Yeah,
CBC?
so yeah, sorry, go ahead, Sarah.
No, it's okay. You can go ahead.
لا والله حلفت. Go ahead, Sarah.
Okay, fair. So it's always great to start with basic things like CBC, CMPs, and stuff like that. So in this case, I would do a CBC more mainly to look for an increase of white blood cells for the diagnosis of cellulitis rather than the DVT itself. Okay.
Okay.
Any other tests? Have you heard of a D-dimer test?
Yes.
Do you think it's something that you'd like to order on this patient?
I don't think so. Because she, I don't know really. Low risk, I think, for pulmonary embolism.
So I agree with you in that a D-dimer test is usually done to help rule out the diagnosis in a low risk population. But do you feel like this is a patient who's a low risk?
Yes.
And how do you determine whether or not a patient is a low or a high risk? There's a certain scoring system that we can use, if you know it.
Givna test? Givna, I don't know.
The what? I'm sorry?
Givna or Wells criteria?
The Wells criteria, exactly. And if you don't know it, you can Google it right now. It's fine because it's a test that you can use in patients who are suspected to have DVT. So how much would be the score for this patient on a Wells criteria? You can pull it up. It's fine because we do in the hospitals too. We use apps to calculate it. We don't use our brains anymore.
Yeah, I'm Googling as well. So guys, relax. Everything is good. Before the wells, I just want to ask one question. What's the difference between a test that rules out or rules in? Guys, you gotta, come in and help Aisha. When Shabab, where's everybody? Yeah, let me make it an open discussion. The idea behind this is simple. If somebody um, comes in with recent knee surgery or hip surgery and develops severe leg swelling and leg pain, and happens to be traveling again from the UK or a transatlantic flight following surgery to Dubai or to Abu Dhabi, and happens to be smoker, and happens to be recently diagnosed with cancer, and happens to have all of those risk factors for venous thromboembolism, and you do a D dimer and the patient is short of breath, you do a D dimer and the D dimer is negative, what are you going to think about the D dimer?
Is it specific or sensitive? Do you mean like this?
Yes, excellent, excellent. Which means if the pretest likelihood of disease is high, D dimers are excellent for a rule out. Meaning if the D dimers are negative, that means the patient is unlikely to be having a DVT. If the patient comes in with sepsis, other reasons for leg swelling and leg pain, if the D dimers are positive, this doesn't mean that they have a PE. So that's why it's important to know that it's a very good rule out test and it is basically done in the emergency room. The other limitation of the D dimer, which is very important, if the clinical suspicion of an acute pulmonary embolism is very high, then the D dimer is not the next best test for investigation. If the patient is coming with hypotension, sinus tachycardia, strain on the ECG, hypoxia, all signs and symptoms of a possible PE, then the D dimer is not going to be the best test. You need to do a more definitive test, especially if they have pulmonary manifestations. So with that, then we'll go with Sarah with the Wells criteria.
Okay. So Aisha, did you manage to calculate it for us in this patient?
Yeah, she is moderate risk.
What is the number that came up with you?
3.16% chance of getting PE.
What is the absolute number? Not the percentage.
3 point. I don't know.
I'm not sure if the calculator that you're using shows it, but in her case, her Wells score was 4, and a 4 means a DVT is likely and ultrasound should be ordered. Okay. A D dimer, as I said, is used in a low risk population in which the Wells score is 2 or less to rule out rather than to rule in. Okay.
Oh, okay. Okay.
Other than an ultrasound, anything else that you want to order in the labs? Again, think of your differentials, and based on that, that's how you order labs and imaging.
Maybe C-reactive protein or inflammation.
Okay, we can do that. Anything else?
No.
All right. Dr. Fahed, is there anything that you'd like to add before I go through the labs and the imaging?
Yeah, I mean, sometimes patients with venous thromboembolism will present with, signs of inflammation, which means they might have a kind of a low-grade fever, they might have an elevated white cell count, they might even have an elevated CRP. So these are things that are, important not to miss. The ECG again becomes very important because, it shows you if there is probable evidence of pulmonary embolism. The classical ECG finding is sinus tachycardia. However, you can get in 20% of patients the classical S1Q3T3. Everybody loves that. Everybody kind of takes a souvenir ECG with it when they see it. So, and that's one. Signs of RV strain, such as RVH, which is tall R waves in the anterior leads, V1, V2, and also right bundle branch block are also signs of venous thromboembolism, pulmonary embolism, as well as a new onset atrial fibrillation.
Okay. Thank you, Dr. Fahed. So, the things that were ordered for this patient in the ER was a CBC, which showed a white blood cell count of 12 with left shift. Just means it's slightly elevated. She had a CRP of 99, which is again quite elevated as well. They did a PT-PTT, but that was normal. They did a CMP, complete metabolic panel, and that was normal as well. And they did do a D-dimer, which was more than 4. But Aisha, do you agree with them doing a D-dimer in this case?
Yes.
Okay. It was more than 4. The imaging, they did an ultrasound of the lower limbs, and it showed extensive occlusive DVT in the left common femoral, the left deep femoral, the left proximal, mid, and distal femoral, and the popliteal and the calf veins. So very extensive DVTs on the left leg. Okay. And because they felt like the clot burden on the leg was very, very extensive, they decided to go ahead and do a CT angiogram or to rule out a PE. And actually, there were a couple of PEs. There were pulmonary arterial emboli within the left upper and lower lobes, segmental and subsegmental branches. Unfortunately, an ECG was not done. So I cannot tell you what the result of that was. And an echo was also was not done. And an echo was ordered, but only done 4 days after her admission. And I can tell you that there was no RV strain seen on echo 4 days later. So, Aisha, what is the diagnosis from the labs that we have and the imaging that we have?
So pulmonary embolism. We need immediate, I think, thrombolytic therapy.
Okay, before we go to the PE, don't you think the DVT is which do you think is worse in this patient right now? Is it the DVT or the PE?
I don't know. Maybe pulmonary embolism is life-threatening.
Okay, I understand you choosing the pulmonary embolism because, when we're taught it's something fatal and scary and has to be dealt with immediately. But let's go back to her exam. She's quite stable, correct? And she doesn't really have any respiratory symptoms as well. It's only the leg that's been bothering her the most and what brought her to the ER in the first place. And if we go to the CT report, it says it's a segmental and a subsegmental. It has segmental and subsegmental pulmonary emboli. And those branches of the lung are actually end vessel arteries, so they don't supply very large amounts of lungs. So PEs there are times where PEs are not fatal and they're not symptomatic. And actually, if they do affect the subsegmental regions of the lungs, sometimes in a patient that doesn't have a lot of risk factors, of course, sometimes they don't even treat it, they just watch it. So, but in this patient's case, of course, like she does have quite a few risk factors. So I would probably try and treat the DVT. Either way, the treatment is the same, but I would think of the DVT as the more concerning problem at the moment. All right?
Oh, okay.
So in this case, this patient was diagnosed with early phlegmasia albadolens. I don't know if you've read this before, but we'll talk about it later on. Phlegmasia albadolens, secondary to extensive left lower limb DVT with an incidental PE. Okay, before we go to the discussion, Dr. Fahad, would you like to add anything regarding the case itself or the diagnosis itself?
Yeah, yeah. So with this type of presentation, this subtype of DVT shows extensive swelling of the legs and stretching. I mean, I wish we had a picture, maybe we can post it, stretching of the skin. And usually what happens in these phlegmasias is that the cutaneous nerves are actually stretched, and that's why the pathophysiology of pain is not the vein thrombosis, but it's actually type of a neuropathic pain, because the vasovasorum, which is the main supplier to the superficial skin, also gets stretched. So that's why these patients, I can see why the interest is to try to relieve the clot burden on the leg, especially that it's upper. So I'm sure we're going to talk about its management, but I'm going to sidetrack to one of the teaching points about venous thromboembolism. So venous thromboembolism knows no friend and has no mercy, which means that if I asked what is the common presentation of DVT or venous thromboembolism, you'd be very surprised. And although it is the most common because it's the most drastic, which is sudden death. Okay, so as you start your internship, as you start hearing the code blue in your hospital, and as you start purchasing your new Nike shoes, I don't write everything I say. As you start purchasing your new Nike shoes to run for the code blues, you'll notice that the orthopedic is notorious for pulsus electrical activity and asystoles because of massive PEs. It's just something to know. Now, the treatment algorithm, as we're going to outline, is very important because the initial treatment is the same, which is anticoagulation, and we're going to talk about this. But that's very important, and this is a very kind of subtype of presentation of leg edema and leg swelling, and this should be very high on the differential. Excellent job.
Okay. Aisha, any comments or questions about the case before we move on to the discussion about edema and DVTs?
I just want to ask, as this female in her 38 year, if she was pregnant, what should I do about the CT angiogram?
You mean treatment-wise?
No, if she was pregnant, for example, pregnant, do we do CT or what should we do?
This is a great question, because now you not only have the mother at threaten, but you have also the baby at threaten. And pregnancy in itself increases the risk of venous thromboembolism, mostly as you approach the trimester and towards the third trimester, because the gravid uterus compresses the IVC and increases venous status there. Now, the problem, and I know what you're thinking, Aisha, is do I do a CT and subject this baby for radiation? Radiation is more worrisome in preconception and in the first trimester. Radiation can be given, but what I would usually do is consider a VQ scan, a ventilation perfusion scan, in these patients as an intermediate test to see if that's helpful. If at times this is not diagnostic, one has to bite the bullet and do the CT if the clinical suspicion is very high for venous thromboembolism. I have to tell you, during my younger age, I had a patient who was pregnant, long flight, came in with a DVT. We wanted to start heparin. The patient kind of refused. And then we did a VQ scan, which was indeterminate, and we wanted to do a CT, and the patient also refused to do a CT. 3 or 4 days later, she kind of decompensated and had a submassive PE. So this is very important. This is a very precious time where you have not only mom at risk, but mom and baby at risk. Good question, Ash.
Okay, thank you, Doctor.
Thank you, Aisha, for your question. Um, now we're going to discuss a little bit about how to approach a case of peripheral edema. So when you have a patient like this who presents to you with edema, it's important to go back to the basics of fluid balance physiology. So as you may remember or may not, total body water is distributed into two parts, two-thirds in the intercellular fluid compartment and one-third in the extracellular fluid compartment. The extracellular one is further divided into intravascular and interstitial. The movement between all of these compartments are mediated by an interplay of the Starling forces, which are the hydrostatic pressures, oncotic pressures, capillary permeability, and the lymphatic system as well. There are four general mechanisms of edema formation, and one is increased capillary hydrostatic pressure, decreased capillary oncotic pressure, increased interstitial oncotic pressure, and increased capillary permeability. So I don't really have a board for me to show you guys, but let's all imagine a tube, and we're going to pretend that tube is a capillary, okay? Have two arrows coming pointing out of that tube and two of them coming out of it. So the inward forces, or the arrows that are going into the capillary, those are usually the hydrostatic pressures of the interstitial fluid and the plasma colloid osmotic pressures. Those are coming in. They're the ones driving absorption into the capillary. The ones that are pointing outwards, which are the ones that drive filtration or bring the fluid out of the capillary, and those are the hydrostatic pressures of blood in the capillary and interstitial fluid colloid osmotic pressure. Okay? So if we were to classify the causes of edema based on these four general mechanisms, we're going to get. The first one, if we think about the causes of edema related to increased capillary pressure. This happens when the lymphatic system reaches maximal drainage capacity, so it leads to a buildup of fluid and eventually edema. And causes of these common causes are at least heart failure, renal failure, cirrhosis, DVTs, venous insufficiency, pregnancy, some medications, superior vena cava syndrome. Second, the causes of edema related to a decrease of capillary oncotic pressure. Now, capillary oncotic pressure is generated by plasma proteins. So any decrease in plasma proteins is going to cause a decrease of capillary oncotic pressure. And conditions that can lead to that are liver disease, malnutrition, nephrotic syndrome, or any protein-losing enteropathy. The third mechanism is increased interstitial oncotic pressure, and this usually just has two main causes, which is lymphedema and myxedema, because interstitial oncotic pressure is generated by glycosaminoglycans and filtered proteins. So you can just remember lymphedema and myxedema for this one. The last one is causes of edema related to increased capillary permeability, and this is seen in cases of local inflammation, preeclampsia, angioedema, or capillary leak syndrome. Okay. Right. So if we move on now to physical examination in a case of edema, what do you look for exactly? And Aisha did this very well during the examination. Is first that you think about the distribution. Is it unilateral? Is it bilateral? Is it generalized all over the body? Because those three things can change your differentials immensely. The quality of the edema, is it pitting? Is it non-pitting? Do you see any varicose veins? Is there medial malleolar involvement? And then you think about systemic diseases. Is it cardiac? Do you see a JVP? Do you hear crackles? Is it hepatic? Is there ascites? Is there scleral icterus or any other stigmata or of liver disease? So when you present an examination of edema, it's nice to be very detailed about it because it tells you a lot. All right. Dr. Fahd, any additions to that before I talk about DVT and phlegmasia albidolens?
Yeah, I think that's a very extensive outline. You can go ahead.
Okay. So let's switch gears now and talk about DVT and phlegmasia albidolens. So DVT, as you all know, is a formation of a blood clot in a deep vein, very commonly seen in the legs and the pelvis as well. Symptoms can include pain, swelling, redness, enlarged veins in the affected area, but some DVTs go unnoticed because they are asymptomatic. The most common life-threatening concern with a DVT is the potential for a clot to embolize, becoming a pulmonary embolism. And both DVTs and PEs are considered as part of the same overall disease process called venous thromboembolisms. So VTEs can occur only as a DVT or can occur as a PE with a DVT or with a PE without a DVT. So it can manifest in different ways. The mechanism of clot formation typically involves a certain triad. Aisha, do you know what that triad is? The three things that can lead to clotting?
Uh, Not sure. Do you mean tachycardia, tachypnea?
No. What are the three things that can cause a clot? Or the name of the triad, at least.
Hypercoagulability.
Yes. Yeah, that one. Do you know what the name of that triad is?
I forget.
The Virchow's triad. But you got one of them right, hypercoagulability. So it's a combination of decreased blood flow rate, hypercoagulability, and injury to the blood vessel wall. And risk factors of VTEs, as Aisha had mentioned also during the case, include recent surgery, older age, active cancer, obesity, a personal history or a family history of VTEs, trauma, lack of movement, OCPs, pregnancy, and antiphospholipid syndrome. So we covered quite a few of those during the case itself. Patients suspected of having a DVT can be assessed using a prediction rule such as the Wells criteria, which we had already talked about. And this is used for patients who are unlikely to have a DVT. And the things that go into this criteria, I honestly can't remember. We always use a calculator in the hospital. So again, something you can Google on your own. That's for the Wells score. And a D-dimer, like I mentioned, is used to assist in excluding the diagnosis of DVT in a low-risk population. Okay, and treatment is usually with anticoagulation, and the choice is personalized based on the patient, and the duration is also personalized on whether or not this is a provoked, non-provoked, or VTE that's caused by cancer. Because unprovoked cancer, cancers patients who have a DVT or a PE usually have anticoagulation indefinitely for life or until the cancer is cured. Patients who come with a VTE that is provoked usually have it for 3 months. And patients who come in with an unprovoked DVT, it's 3 to 6 months, but again, depends on the patient and is personalized based on that patient's comorbidities and things like that. Okay. All right. Now let's talk about the more rare diseases on the more serious spectrum of VTEs or DVTs. They are Phlegmasia alba dolens and Phlegmasia cerulea dolens. And this is what the patient has, Phlegmasia alba dolens. Our patient was diagnosed with Phlegmasia alba dolens, which literally translate to painful white inflammation. And this occurs when a venous thrombosis progressive to such massive occlusion of the deep venous system of the legs, but without ischemia, because the collateral veins are still patent and can still feed that leg. Phlegmasia cerulea dolens translate to painful blue inflammation, and that is the next progression of the disease after. And this is characterized by complete thrombosis of the venous system, including the collateral circulation. So this, in the end, results in significant venous congestion, fluid secretation, worsening edema, and if it's left untreated, it will progress to venous gangrene and cause massive tissue death of that affected limb. The overall incidence of this disease is not very well documented, but it is noted to be occurring more in women, in people in the 5th and 6th decades of their life, in the left lower limb extremity compared to the right. And most patients have risk factors such as malignancy, hypercoagulable state, surgery, trauma, IVC placement, or pregnancy. And the most common risk factor is malignancy, which is seen in 20 to 40% of the cases. To diagnose this, ultrasound is the best initial imaging for suspected DVT and Phlegmasia alba or cerulea dolens. It's quick, it's fast, it tells you diagnosis quickly. Treatment-wise, the initiation of anticoagulation is the standard and routine of care. They must always be started on anticoagulation immediately. So the management of Phlegmasia alba dolens and milder cases of Phlegmasia cerulea dolens includes initiation of heparin infusion, warfarin bridging, fluid resuscitation, and limb elevation. And decisions regarding the management of the more severe cases of Phlegmasia cerulea dolens are still evolving. They do consider things like thrombolytic therapy or surgical mechanical thrombectomy, but those are things that are taken on a case-to-case basis, and there's not really a guideline for those kinds of things in this condition. So the main complication that we all worry about is pulmonary emboli, and should always be considered during evaluation and treatment. The overall mortality rate of Phlegmasia cerulea dolens is 20 to 40%, and pulmonary emboli are believed to be responsible for at least 30% of those cases. And again, it's important to note that not all PEs are fatal or symptomatic, such as the one in this patient's case. But again, it's always something important to keep as a differential in mind in a patient who comes in with very clear DVT, especially one as extensive as our patient here. All right. Any questions, any additions before I go on to the case conclusion to what happened to this patient?
So just before the case conclusion, Sarah, very nice outline, of the case and the data. I posed a question for the group about a kind of a multiple choice question about what's the best treatment. DOACs were not part of the choices on purpose, and a lot of the group answered start low molecular weight heparin. The choices were that, warfarin, aspirin, and IVC filter. Obviously in patients who have a DVT, placing a filter is not going to be helpful unless the patient has a contraindication to anticoagulation. So that's very important. Aspirin actually is an antiplatelet and doesn't work in multiple studies in comparison with antithrombotic therapy. What's the problem with warfarin? Imagine you're working in a very remote area where they don't have DOACs, it's too expensive, you need to put them on warfarin. The patient is demanding to go home, she does not want to sit for low molecular weight heparin or IV heparin. Dr. Sarah said something very nice. I don't know if you've noticed, she said bridging. Bridging is like a jisr, bridge. And the bridging is very important because as you start warfarin, you are going to go into a procoagulant state because you deplete protein C and protein S, meaning that you have to have a heparin antithrombin 3 antagonism during that period. So that's just for you to know. However, the new guidelines now, and Sarah is going to outline them, do talk about DOACs, and they've been shown both in the DVT as well as in the PE world. Okay, I yield to Sarah.
Okay. So thank you for the question, Dr. Fad. So for this patient, she was immediately started on enoxaparin as an inpatient, and she was later discharged on rivaroxaban. Vascular surgery was consulted as well because of the extensive involvement of the leg, and discussed thrombolysis, which is the current recommended treatment for patients who present with her kind of condition with her, but she was very undecided on whether or not she wanted to go to surgery and requested more time to think about it. So in the meantime, more investigations for hypercoagulability were done, such as factor V, B2 glycoprotein, double-stranded DNA, anti-cardiolipin antibodies, lupus anticoagulant, and homocysteine. The only thing that came back positive was a positive lupus anticoagulant. So she was discharged around a week and a half later with anticoagulation and good pain control, and will follow up with vascular surgery and hematology oncology as outpatient to finalize her treatment of whether or not she wants to go ahead with surgery or continue medical management. And that is the case for.
So Sarah, the nice question from Muhammad about the use of where did you go? The use of CT in diagnosing DVT. So ultrasound has a very good sensitivity, but sometimes you might kind of miss smaller branched DVTs. Now, if you combine CT angiography, CTPA, as well as CT of the lower extremities, you have a very high sensitivity for around 98%. So it just increases your diagnostic accuracy. And the only downside of doing CT for the lower limbs is obviously the dye that you're going to give. Most of the times, when you discover somebody presenting with shortness of breath and they have a subsegmental PE, you go scan the legs. And you go scan the legs and you don't find anything. Usually you don't find anything because the birds have already flown. So whatever clot there was there has already traversed and went to the lungs. But PE that's coming from the lungs is definitely coming from either the pelvic veins or they're coming from the deep veins of the leg.
Was there any other questions, or I haven't opened the chat?
Okay, so is there any other questions from the floor? So thank you, Dr. Sara, Dr. Fahad. Honestly, it's been a very comprehensive approach, and I don't know about the rest, but personally, I learned a lot. So if there aren't any more questions, and if Dr. Sara and Dr. Fahad, you don't have anything else to add, we can conclude the session.
I want to thank everybody, but I see two questions, Assyria, which I don't like to leave any questions unanswered. It has one question about one question is about silent PE. Again, PE is a clinical syndrome, and we can talk about PE in a different setting, and we'll have Sarah organize a beautiful case. But there are three main syndromes. Some of them are transiently symptomatic with showering of emboli. Some of them present with pleuritic chest pain when you have a pulmonary infarction, and some of them present with the most dramatic when you have a massive PE. Whether you have a PE that is symptomatic or not, the treatment is the same. The more better question or the better thought was whether it's provoked and unprovoked. And in many cases, we try to find a reason for it to be provoked because the duration of anticoagulation is usually shorter with a 6 months duration. It's patients who have an unprovoked or cancer-related that they might need to be treated for a longer-term anticoagulation. Thank you very much, guys. It's been a pleasure. Hope to, inshallah, see you soon. If you have any questions, just let me know. Contact me in any way with Dr. Sarah, and we're happy to be involved in the teaching.
Thank you very much, Dr. Fahad and Dr. Sarah. I don't see the questions, so if I don't know, Dr. Sarah, if you can see the questions as well, because I guess it's only Dr. Fahad who can see it, because I can't view them for some reason. But if there are any more questions, please.
There's just one more question. Can you get a
Yeah,
DVT in the foot or only in the calf and above? That's the only question that's not answered so far, I think.
Yeah, I think we have time to answer that question.
Dr. Fahad, I'm not really sure of the answer of this question, so if you can assist.
Sorry, what's the question?
Can you get a DVT in the foot alone, or is it only in the calf and above, anatomy-wise?
This is the time where I can escape, huh? Shil Ali. Sorry, I have to go. No, you're absolutely right. So if you go back to the, if you go back to, if you go back to the anatomical diagnosis that we talked about, it is mostly the deep veins that actually where the pathophysiology of clot happens. Now, the deep veins are very important because they are the main pump function that traverses blood from the superficial veins to the deep veins, and in order for those veins to go into the femoral junction. So the foot itself, you can't get a DVT inside the foot. The foot has superficial veins, but it is the deep calf veins embedded between the gastrocnemic muscle and the soleus muscle is where the clot develops. Now, this clot can occur more proximal, where you can go it in the popliteal, and it can definitely become more extensive to the femoral. So the clot is like a snake, it's like an anaconda that grows with time, and then the problem is when it breaks off and goes to the lungs. So you're talking about deep veins, meaning calf, popliteal, and femoral, and then pelvic. These are the 3 or 4 areas where a clot, deep vein, can occur.
Right. Thank you, Dr. Fahad. I just wanted to say a special thank you to Aisha as well for being our only discussant. I know it's hard being put on the spot like she was, but I think you did a great job and you went through the case very well. So thank you. Well done.
Yeah, I have to commend Aisha as well. MashaAllah, she's brave. It's difficult to be the only discussant. If I was the discussant and you were asking me questions, I would be nervous. And this has advantages. Sometimes when you do it in a team, it helps. But when you're alone as well, you can think on the fly, and it mimics hopefully real life situations. But again, it's a pleasure, and looking forward to the next meeting.
Thank you, doctor. Very grateful.
All right, I think we can end it here. So again, thank you, Dr. Sarah, Dr. Fahad. It's been a pleasure, and it's a very comprehensive case. So thank you. Thank you for our attendees, and as well, Asha, thank you for being our only discussant today. I think you did a really great job. So inshallah, we'll meet in other episodes. So take care, everyone, and stay safe. Thank you.
All right. Yalla, bye-bye. Bye.